What's up guys, Zach here with Dr. Eyeball MD, and today I'm going to go over some of the crazy stuff that I see on call. I write it all down here. Let's get into it. You would not think that ophthalmology call would be that bad, or that it would be as infuriating as it can be sometimes. The problem with ophthalmology call is that the doctors that are consulting you don't know anything about the eye. The training you get in med school on the eyes covers about the span of 2 days, maybe 1 day, 2 lectures tops, maybe a few hours on the eye. That's it. And that's the most that most doctors out there will ever get about the eye. And so then you get these things that come through the ER and they have no idea how to even tell the ophthalmologist what's going on half the time. Some of them do, but a lot of them really just don't. And that's not their fault. It's a deficit in the training, in medical school training, is you just don't learn about the eyes unless you go into ophthalmology. And that's great for job security for the ophthalmologist, but it can be kind of stressful on call. So when you have a cardiologist and the ER doctor gets somebody that comes in with chest pain, they're able to say, hey, I've got a guy here with chest pain, this is his heart rate, this is the EKG, we got this study, you think he needs an echo, I think he needs this. The ER doctor can tell the cardiologist what's going on. With the eye, a lot of times someone comes in and all I get is, his eye's red, come look at it, I don't know. So they don't know, half the time they don't check the vision, they don't check the eye pressure, they don't look at the pupils, half the times they don't look at the patient. I ask them what the vision was and they tell me, well, he could see me from the door. They'll literally tell me that. Anyways, so I see some pretty crazy stuff on call. I work at, so when we take call as a resident, as a first year, we're covering 3 different hospitals: a private hospital, a county hospital, and a neuro hospital, a neurology hospital. Most of the calls come from the county hospital. Probably about 80 to 90% of them come from the county hospital. Another 10-15% come from, 10 to 20% come from the private hospital, and then we get maybe a few here or there from the neurology hospital. And call gets crazy. The way we do call is you either do a Friday and a Sunday, Friday night from 4 p.m. to Saturday at 7 a.m. Then you have Saturday off and you start back on Sunday at 7 a.m. until Monday at 7 a.m. and then we start in clinic on Monday at 8:30. So that can be rough. And then there's somebody that takes the Saturday call from Saturday at 7 a.m. to Sunday at 7 a.m. And so the call can get really busy because you're covering those 3 hospitals. There's a private line that patients in the attendings clinics can call into with basically any question, and it comes straight to you at any time of the night for any question they may have, any med refills that they need, and that comes straight to us. So what I do is I have a system where I write in this notebook, just because you can get so backed up, you can get 5-6 consults deep, so you need to write down and know what you have on the list. So I have it all documented from this last week's call. I was on a Friday-Sunday call, and it's all documented here, all the cases. I saw some pretty crazy stuff. I wanted to take you guys with me and actually film the call day as it went, but it just got a little too busy, a little too hectic, so I couldn't film it all. I will take you guys on my next call, though. I think that'll be next Friday. I'm going to try to take you guys along with me. But I just want to talk about some of the stuff I see, because you never think that this stuff can happen, but it does. First guy is an inpatient on our service, the ophthalmology service, corneal ulcer, fungal ulcer, most likely. Basically, this guy only has one good eye, the other eye doesn't see, and in his good eye has a fungal ulcer. Another corneal ulcer, younger lady, actually, with a really, really bad corneal ulcer. May have actually been a canthamoeba, so not a bacteria, not a fungus, possibly a canthamoeba. We think maybe fungus or a canthamoeba because it wasn't responding to antibiotics, and antibiotics treat bacterial ulcers. So a canthamoeba is something we see in contact lens wearers a lot of times. It's a amoeba, it's a protozoan that causes terrible, terrible keratitis and can just eat right through the cornea. So 2 corneal ulcers on our service that we're seeing. Another patient we're consulted on with maxillary mucormycosis. So mucormycosis is it's a fungus that essentially occurs in people with diabetic ketoacidosis a lot of times. So people with really high blood sugars are prone to infection. They get these fungal infections that will just eat right through the face, up through the sinuses, into the orbit, into the brain, and is almost always fatal once it really gets going. So she had maxillary mucormycosis fungus in the sinuses here, on the left side in this sinus, Fortunately, it had not come to involve the orbit or the eye yet, so we were just making sure that it wasn't, and it had not, at least when I saw her. So that was just a patient we were consulted on. Another patient we were consulted on and just following, just with terrible pustular psoriasis, who intubated, sedated, and when those patients, their eyes a lot of times don't close all the way when they're sedated, and so you can get exposure, dryness of the lower cornea. It dries out, it gets very dry, it gets abrasions, it gets epithelial defects, and then it gets infections, corneal ulcers, and it can be bad. A lot of times we actually have to go in and, or some of the times we have to go in and actually sew the eyelids closed, do what we call a temporary tarsorrhaphy, closing the eyelids, sometimes even a permanent tarsorrhaphy if it gets bad enough. And then the next patient, this was probably the saddest patient of the day. If you can believe it can get worse than those things. A young guy, in his mid-20s with neurosyphilis, meaning syphilis that's gone through the primary, secondary, and is in the tertiary phase where it becomes neurosyphilis. It gets around the brain, it gets in the cerebrospinal fluid, around the spinal cord, and the eyes are just an extension of the brain, so it makes its way and can cause really bad posterior uveitis, a lot of inflammation in the eyes, to the point where you can barely see. It can be devastating. So very bad. Once he's getting treatment, we can start treatment for the syphilis. We can start steroids to help control the inflammation and help improve the vision. But unfortunately, he had already had a retinal detachment in one eye, probably from just complications of that and the inflammation. The other eye hopefully can be salvaged once the inflammation gets taken care of. Next patient I saw was a guy with what we call an open globe injury. So this is one of the few true ophthalmologic emergencies. One of the true eye emergencies is what we call a globe. Just among residents, it's called a globe. What it actually is when the eyeball is in some way pierced, open, lacerated. There's a communication between the outside world and the inside of the eye, which is not ideal, obviously. So this gentleman had gotten punched in the eye and had a large scleral laceration temporally that had to be sutured closed with 4 sutures. The globe was deformed. Normally the eye is round. The back of the eye on the CT scan was just indented because of the loss of pressure inside the eye. Somehow, post-op day 1, he was seeing 2200, which was pretty amazing given the extent of that injury. And I don't know, you don't normally get a laceration to the eye, just getting punched in the eye, unless there's something sharp that's going to cut, like brass knuckles or something else that hits the eye. So all of this is just stuff that I walk into on the day, like Sunday, these inpatients that I'm seeing before any consults or new things in the ER. So this is just all stuff on the plate that you walk into Sunday morning. So it's a lot going on. So the first consult that I actually got was on a lady who the ER calls me and says she's just having foreign body sensation in her eyes, like sand in her eyes, but it's been getting blurry over the past week. I go to see her. She has terrible disc edema on fundus exam. She has an APD, meaning the pupil's not constricting properly and it's actually dilating when light shined at it. So there's some problem with the optic nerve. I dilate her. She has bad papilledema in that eye, probably optic neuritis. So we asked neurology to see her. And sometimes those patients can get admitted for high-dose IV steroids to actually improve, or rather, to speed up their visual recovery, although it doesn't necessarily improve their final visual outcome. So we were able to help her, I think, by diagnosing that and getting her plugged in with neurology. So the next patient I saw was actually at the private hospital, a lady who had had cataract surgery a few weeks back, now having redness, watery eye. So you gotta be careful with those post-op patients. They can develop what's called endophthalmitis, where they get infection inside the eye, and basically bacteria grows, and it can be bad infection. A guy who had a corneal transplant for keratoconus, then having a lot of pain, blurry vision, watery eyes, and he was coming in for an epithelial defect, basically a scrape on the cornea that was already there, but I don't know why he decided to go to the ER this day. It had been there for weeks. So next patient was a pregnant lady who had come in. We had already done most of the evaluation on a few days prior, and then she left AMA, so against medical advice, before we could finish the dilated fundus exam. And what we were looking for in her was elevated pressure around the brain that we thought might be causing papilledema. So like IH, like idiopathic intracranial hypertension or some other reason for her to have elevated pressure based on some of the stuff she had from an outside optometrist. So she came back on the weekend, and so I had to finish the dilated fundus exam on her. Sure enough, she had 1 to 2 plus papilledema both eyes. So she's getting the imaging, lab work, and then spinal tap. Once the imaging's negative and rule out risk of herniating with the spinal tap, then she gets the spinal tap. We measure opening pressure, and it gives us an idea of the pressure around the brain, pressure around the spinal cord. And like I said earlier, that's all connected to the eyes. So when that pressure goes up around the spinal cord, it goes up around the brain, it goes up around the optic nerves, puts pressure on those nerves, and can cause damage to those nerves. So that's what we were doing with her. Next patient was back over, so driving back across town to the private hospital for a patient with varicella zoster, so shingles in this part of the face that can involve the eye, and he had a mild conjunctivitis from that, but no uveitis, meaning inflammation in the eye. It can cause a retinitis rarely, like something that's actually called ARN or PORN, acute retinal necrosis, or progressive outer retinal necrosis. There actually is a disease called PORN that can happen in the eye. He didn't have any of that, just mild conjunctivitis, good vision. So we got him on the right therapy for the shingles and moved on. Next ones I didn't write down because it was, I think, 3:30 in the morning before I got paged again, and I didn't feel like writing anything. So the consult that I got at 3:30 was for Stevens-Johnson syndrome, a girl that had been started on multiple psych meds. One of them was carbamazepine, and that can cause Stevens-Johnson syndrome, where people will break out in a skin rash all over the body, which can be very, very dangerous and even deadly. And it affects the mucous membranes to the mouth, oropharynx, that kind of thing, and the eyes. It can affect the eyes, it can cause scarring, and it can cause really bad problems in the eyes. Fortunately, she didn't have any issues with the eyes. I went to see her at 3:30. She wouldn't let me put drops in her eyes, so I couldn't do the full exam, but it didn't look like she had any ocular involvement, which was good. And then 7 o'clock Monday morning is approaching. I'm in bed, or about to have to get up to go to clinic, which starts at 8:30. And at 6:44 a.m. before the shift is over, I get another page from the private hospital for a guy with history of Wegener's granulomatosis, which is a bad vasculitis. And he had it in his orbit. Granulomas all in the orbit with compression of the optic nerve. We had seen him before, but back in the ER now with terrible, terrible pain, worsened vision than before. So I went to see him. I was late to clinic, but he did have a lot worsened vision. And he had already had 2 prior orbitotomies, or orbital decompressions. They went in and basically removed the granulomas from around the nerves before, but it was at this time probably a little too dangerous to go back in and try to operate there. At least that was the thought from our oculoplastics attending. So he got admitted for IV steroids to calm down the inflammation, try to relieve some of that pressure on the nerve, and help prevent more permanent damage to the nerve than he had already had. So that kind of ended Sunday. Those are just some of the things that I see on call. Neurosyphilis, orbital Wegener's granulomatosis, post-op cataract stuff. I saw a lot of zoster, a lot of shingles we see, even when it's not involving the eye. They want us to look at the eye. Stuff like that. Uveitis, optic neuritis, see all kinds of stuff. So call is a great learning experience. I learned a ton of stuff on call. It's very stressful. It's the most stressful part of residency, in my opinion, is being primary call, where you're the doctor that is on call for 3 different hospitals. So if any person at those 3 hospitals comes in with an eye complaint, they're calling you, the first-year resident, who may have been doing this for a few months, to come in and figure out what's going on. Seasoned doctors are calling you, who is now the expert, although you've been doing this for a few months, to come figure out what's going on. With other specialties, all of medical school, you're getting prepared for the most part, unless you're doing another surgical subspecialty, you're getting prepared to learn how to practice in that way. So internal medicine doctors have been practicing in med school, and so it's a much easier transition. With ophthalmology, you start ophthalmology and it's like starting over. Most of what you learned in medical school becomes irrelevant when you start to do ophthalmology. The exam for ophthalmology is so different, so hard. It's something you may have never done, and suddenly you're expected to be able to see these people, be able to examine them, which is a very difficult exam, especially in the beginning, diagnose them, and then know the treatment right from the beginning. It's very, very stressful, It's probably one of the steepest learning curves in any specialty, I would think, just because of how different the specialty is from anything you're taught in medical school. So it's very difficult in that way. Guys, thanks for hanging out. Thanks for watching this. I just wanted you to know some of the stuff that I see on call as an ophthalmology resident. I'm gonna take you guys with me on a call next time. I'll try to keep all the patient information confidential, of course, HIPAA compliant, but I'll take you guys and I'll explain some of the stuff we're doing. I'll give you the times of when I'm seeing stuff, just so you can get an idea of what a call day is like for ophthalmology resident, especially at a really busy program like here where I am that covers multiple hospitals. I hope you guys liked the video. If you did, like and subscribe. I'll try to keep videos coming out, let you follow me along on this journey to become an eye doctor and eye surgeon. And I think it'll be a fun journey. I hope you guys like these videos. Leave a like, subscribe, and I'll be back to take you guys on my next call next Friday. Thanks.